Hello and welcome to the MIMS Learning Clinical Update podcast, the podcast that brings you thought-provoking clinical education that you can fit into your busy life. My name is Dawn Liz Powell and I am medical editor at MIMS Learning. Today I will be speaking to Professor Alex Miras about obesity. Professor Miras is an endocrinologist and is clinical professor of medicine at Ulster University. He is also a member of Obesity Health Alliance, which works to reduce obesity-related ill health by supporting evidence-informed, population-level policies that will reduce the prevalence of excess weight across the UK. Welcome to the podcast, Alex.
Thank you very much for having me.
Okay, so I'm sure our listeners will know this, but what is the definition of obesity?
There's one existing definition of obesity, and there will soon be another one. The one which is already existing is excess adiposity that is impacting on health. So it's not just presence of excess adiposity, but it needs to impact on health in one way or another in the form of functional, mental health, or medical complications. There is a Lancet commissioning exercise at the moment that is expected to report very soon, and that will provide a new definition for obesity, and it will focus very much on obesity being a disease in its own right.
Okay, so the definition of obesity, I think in terms of like clinically diagnosing obesity, and you're sometimes referring to BMI. Now, is it right that if you are of South Asian ethnicity, obesity might start at a lower BMI? I mean, why is this?
Yeah, no, that is a very good point. And we generally focus a bit too much, perhaps, on a white Caucasian type of population when we're using body mass index. But we should not forget that people in South Asia and Eastern Asia, as examples, can develop obesity at lower body mass indices. The reason behind that is that they are more potentially vulnerable even to smaller amounts of excess adiposity in terms of cardiac or metabolic complications compared to a Caucasian population. And that's why there are different cutoffs around the world. Generally speaking, we in the UK, we generally reduce those cutoffs by 2.5 points of body mass index in order to define it, but also to find out if these people are eligible for treatment. And we should also not forget additional measurements that define excess adiposity that are more specifically designed to measure abdominal adiposity, which can be a particular problem in people of all ethnicities, but more so in people of South Asian ethnicities.
Okay, and so just going back there to what you were saying, so you're saying soon we'll have a definition of obesity where we're looking at it as a medical condition where it's not just excess weight, essentially, it's excess weight plus the effect on health. Is it that there are some people who they're naturally a bit plump, or there are people that they can carry a lot of weight and they're okay? So that can happen, that you can have someone who's actually, they look like they're living with obesity, but they're actually healthy kind of otherwise?
Exactly. And what's more important is whether people feel healthy or not. So, what that means is that you can have someone with even high levels of obesity purely measured on BMI. So, body mass index of 60 that can have perfectly normal cholesterol, perfectly normal blood pressure, perfectly normal glucose levels. And they may not complain of any functional, and they may not complain of any mental health complications of the disease of obesity. The other thing that we have learned more recently is that people can have what we call metabolically healthy obesity, which means that their sugar or blood pressure or cholesterol are absolutely normal. This doesn't mean that they are not at higher risk of cardiovascular disease. So they still remain at higher risk of cardiovascular disease, but that is just a risk. Whereas what we're asking is, do they feel healthy at the current moment? And if the person is healthy, then we would not classify them as having the disease of obesity.
I suppose we could talk about that at length, really. But so now, sort of focusing on the people who live with obesity. These are the people who do have cardiovascular concerns, or these are the people with a medical condition. What are the drivers of that type of obesity?
There are two types of drivers. It is usually abdominal adiposity that confers most ill health when it comes to the cardiovascular or metabolic control. Usually, what happens is that excess fat can occupy or infiltrate organs that it shouldn't do, for example, the liver, the pancreas, the heart, and that can cause the complications. However, what people can also have is subcutaneous obesity, which is generally preferable in terms of the two types of obesity because it is not associated with higher cardiometabolic complications. But what subcutaneous obesity does is it can cause the functional complications. So people cannot move, they cannot do the things that they want on a day to day basis. And that is usually the excess fat that affects their joints.
Which patients are most at risk, though? I know, because we're talking about South Asian, but I mean, there's a lot of talk about deprivation and like things like that. There's sort of this stigma about obesity being poor diet and lack of exercise. But are there other factors that are beyond perhaps a person's control?
Okay, that's a very good question. And what we have learned over the last few years, in fact, over the last 2 to 3 decades, I should say, is that the biological underpinnings of obesity account for approximately 70% of someone's predisposition of the developing obesity. It is up to 70% of biology that determines our body weight to start with. And in those people who have got a genetic predisposition, what happens is that that genetic predisposition expresses itself in the brain in order to cause the symptoms of obesity, which are high hunger and low fullness. So there is overeating that is the driver, and that is predominantly biologically driven. But at the same time, that means that we've got an approximately 30% of contribution from the environment. And the environment, in terms of multiple external factors, one of them, as you mentioned, is deprivation, stress, emotional eating, etc. So when we are addressing obesity, we should be addressing both of those factors, both the biological and the environmental. And the reason why deprivation causes obesity is because, or predisposes to obesity, not causes obesity, is because deprivation can be associated with stress, can be associated with less time to look after one's self, someone's health. Stress eating, emotional eating can contribute to weight gain. But it's important to understand that even if you go to a deprived neighborhood and you measure people's weight, you will still see a normal distribution of body weight. When I say normal distribution, it means that most people will be around the average. There will be people on the one hand will be heavier, and there will be other people who are less heavy than the average. And what I'm trying to say is that in the same environment, it is not environment that determines the distribution of someone's body weight in that range. It is biology. It is just that the mean weight of a population within a deprived area is higher compared to a non-deprived area.
Okay, so talking now about addressing obesity, or you've got a GP and they've seen a patient of theirs and they think that patient perhaps is living with obesity. How it's such a sensitive issue, wait, how does a GP address that issue and like do it sensitively?
Yeah, so the mistake that we have been making as healthcare professionals, either GPs, hospital specialists, nurses, etc., is that we're very quick to jump and say, you need to lose weight, as if the person sitting in front of us has never thought of that. People don't always respond well to that. And the reason is that they might not be ready to start on their weight loss journey. There will be other people who just didn't even realize that obesity was affecting their health. So A slightly better way of approaching this is to ask permission. That means that we ask the person, is this a good time to talk about your weight? Okay. And that gives a lot more freedom to the individual to say yes or no. I am in a position to talk about my weight now, or I know that my weight is an issue, but I don't want to talk about it. And there will be most people respond well to that because it shows this sensitivity from the healthcare professional side. There will be other people who say no. Saying that, most people actually, when they understand that you're approaching this from a different angle, they will come back to you perhaps on a different consultation and say, thank you for asking me last time. I am now ready to discuss my weight. And the first bit, which is ask, comes from what we call the 5 A's of the Canadian guidelines of managing obesity and being sensitive about it.
Presuming the person doesn't want to address the issue of obesity at that point in time, but then they're coming back with like signs and symptoms of diabetes or perhaps some sort of blood pressure. And how do you then strike that balance? Because you've got to respect the fact that they might not want to talk about their weight, but they are then coming in with conditions that would be helped with them losing weight. So how do GPs or healthcare professionals strike that balance between helping them with those issues, but also making them aware like this obesity is a factor in these conditions?
That's a good point. I think you need to be very clear. And when they are saying that the person is not responding, I think we need to be clear and say that I think, as a healthcare professional, that your diabetes control or your new hypertension is associated with your weight. So we need to make that clear. We cannot hide behind that. And then, but you made it clear, then you still need to say, would this be a good time to talk about your weight and obesity? And if the person doesn't want to talk about it, then you go ahead and you treat the diabetes or the cholesterol or the blood pressure with medications that we have perfectly well working now without addressing their weight. So it still gives quite a bit of flexibility to both parties. And I must say to you that I think that it is generally uncommon for people to keep not wanting to address their weight.
I was just thinking about my mum. My mother lived with obesity and she didn't like going to the doctors anyway. And I think one of the reasons she never went to the doctors was because she thought, oh, they're just going to lecture me about the weight. So I think that just kind of shows how insensitively things are done.
Yeah, you're right. And the other mistake that we make is we over attribute many things to obesity. So every time someone comes to me with a different symptom, we always say, "Ah, it's because of your weight." Okay. Whereas, and that is important. That we do the same in diabetes very frequently, and we need to be very careful when we're doing that because not every symptom will be related to obesity, and we should not forget of the differential diagnosis that we need to explore before ending up again attributing their symptoms to excess weight.
So just thinking about the NICE guidelines, I mean, obviously there's been so much talk about semaglutide and tirzepatide, I think it is, these weight loss drugs. But NICE sort of say before you can think about these drugs, you've got to be thinking about lifestyle, behavior, and all these different approaches. So how can a GP help someone with obesity who does want to address obesity? How can a GP help them perhaps look at their lifestyle, look at the behaviors? I mean, how can a GP help them do that?
I must say that most people that go to the GP or even come to me in clinic, they would have already tried what we call self-directed weight loss approaches. Okay, so the thing that we can add to that are more structured behavioral modification approaches, which are, however, tailored to what the individual has already tried. And the difference being that they are usually delivered by a team of professionals. they need to be ideally also be personalized to the needs of the person that is coming in front of us. So if we identify more psychological aspects contribute to overeating, we need to address those. There's no point giving people, specific diets, etc., if we identify a specific driver to their obesity. And there's also no point repeating specific diets if the person has tried them many times before. That is another mistake that we make. We do not have agility when it comes to assessing our intervention, and we can do that within 3 months of starting the intervention. If people have not lost weight, there is no point repeating that. We just need to have agility and change to a different intervention that may work.
Okay, and just talking about dietary intervention, the soups and shakes diet's had a lot of press. I mean, it's kind of gone a bit quiet now because there's so much talk about weight loss drugs. But what do you think of that intervention of like the whole soups and shakes thing, the whole like putting diabetes into remission?
Very good point, and one that has been rather controversial. The problem is that when you ask people to do something which is not maintainable in the long run, then guess what happens? People lose weight and they regain most of the weight that they have lost. That is not an absolute. There will still be people where you ask them to have a low energy diet, which is what you are referring to in the direct trial. So people in that study were consuming about 800 calories for 3 months, which is tough. And then they had food reintroduction, which included milkshakes, etc., as meal replacements. And maybe one milkshake a day, etc., is okay, but having a total meal replacement is not exactly a fun way of living. So, what I would say is that the reason why this has gone a bit quiet recently is because the 5-year results of the direct trial have now been published, and there's so unfortunately a large amount of weight gain that takes place beyond the first year. So I would say for those people that can do it, fantastic, carry on, and they can have many improvements, including putting their diabetes into remission. But for the vast majority of people that cannot do this, just asking them to eat less makes less physiological sense than we previously thought, because asking people to generally reduce their energy intake, and certainly when we ask them to reduce their energy intake to such a substantial degree, what happens is that their body reacts to that, and it sabotages not only the current weight loss attempt but also future weight loss attempts. The part of our brain that controls our body weight is very sophisticated. And just asking people to eat less, I'm afraid, is not sophisticated enough.
I think anybody who's ever tried to lose weight knows that the losing weight bit isn't the difficulty, it's the keeping it off. Okay, so now on to the drugs. Which patients living with obesity do you think will benefit the most from a weight loss drug?
In terms of response to the drugs, when it comes to just purely weight loss, we don't know at baseline who will respond and who will not respond. Okay, so there are no predictive markers, or there are very few and generally crude predictive markers. Again, you trial it for 3 months and then decide whether it's working or not. When it comes to specific subpopulations that will benefit from their health the most, there are specific categories of people that would benefit, and those are some examples I will give: people with cardiovascular disease, type 2 diabetes, women with infertility, people who have got the functional complications when it comes to their joints, people with fatty liver disease. These are some of the key categories of people that stand to benefit the most. It doesn't mean that other groups of people will not benefit, but considering the landscape at the moment, the fact that we don't have enough resourced obesity services and we don't have the finances to fund the drugs for everyone, we have to unfortunately prioritize. And these are some of the populations that stand to benefit the most. Over time, when things become better, when we do have better services and when the drugs do become cheaper, then we will be able to scale them to a much larger population of individuals with a condition. The people that stand definitely not to benefit from these interventions are people who just want to look better when they look at themselves in the mirror. So these are not cosmetic treatments. These are for people who have obesity and its serious complications.
Do you think, just talking about the people who buy it privately, do you think there needs to be more done to make people aware? Like, because there's been sort of in the press sometimes about the side effects of these drugs, and the kind of reality is obviously all drugs have side effects, but the ones who are going to really have the bad side effects are the ones who don't need it in the first place. So, does more need to be raised awareness of how bad an idea that this is?
Yeah, so I will tell you what would be a priority in terms of awareness. And that is that these medications, if are to be started, are not to be stopped. And the biggest harm that these people are doing to themselves is assuming that they will take the medication for 6 months and then stop taking it and they will be fine. They will be able to maintain the weight loss. Unfortunately, science is telling us that that is unlikely to happen in the vast majority of people. And that's the thing that I keep telling people that either don't need the medication or even people who need the medication. This is not a short term treatment. When it comes to side effects, well, the good news is that these medications are overall very, very safe. So even if people say abuse them that don't need it, they are likely to be okay. They might have the side effects that again there needs to be awareness about, you're right, when it comes to the gastrointestinal side effects and the rather rare risk of developing cholecystitis or pancreatitis, but that's about it. So the vast majority of people are able to tolerate them without harming their health too much. It is the weight regain that tends to be the problem, and of course, unnecessary use. So, for people who have a normal body mass index, or even in people who have anorexia. Remember that the license for all of those medications is that they need to be taken long term. Now, NICE, that assesses cost effectiveness, not the license, have decided that liraglutide and semaglutide they can only be used for up to 2 years purely based on cost effectiveness measurements. It makes no clinical sense stopping these drugs at 2 years, in the same way that it doesn't make any clinical sense stopping an antihypertensive after 2 years. Now, it looks like nice guidance on tirzepatide will allow its use long term, which I think is a positive step forward.
So, say things change, and NICE sort of says, "Oh, all weight loss drugs can be used indefinitely because that's what can be used long term." At the moment, they're once weekly injections. Do you think like we need to have weight loss drugs that are perhaps a little bit more accessible, like perhaps in oral form or something a little bit easier to take?
Yeah, now remember that these are medications that are self administered. So people don't need to attend their GP or the hospital to have them administered because they are simple subcutaneous injections in the same way that people self-administer insulin. Now, is that a barrier to people using them? Well, surprisingly not. The reason is that when people lose weight, they're so grateful that they really don't mind the weekly injections. When these medications came out, there were twice a daily injections, and now they have moved to once weekly. So they have already become more user friendly. And correct, number one, they might become even monthly injections, again, making it easier that people can self administer. And the companies are working on that, be manufactured into pills. Usually, people will need to take them on a daily basis, but that is something that many people would prefer compared to having injections. And it is the fact that we are going to have so many choices in the future that we will be able to offer them to people, and then they can choose whichever one is best for them. So we will be able to address and to treat a number of different populations depending on their preferences and needs. A few cautions. These medications should not be taken by women close to conception because there are some theoretical, at least, risk of teratogenicity based on the animal studies. They should generally be avoided in breastfeeding, even though we don't really have evidence that that is harmful, but probably best avoided. And certainly should be avoided during pregnancy. I also wanted to say that at the moment, even though they are available and eventually will be approved by NICE, I'm referring to tirzepatide, the difficulty that people have is access. And even if we had all of the money in the world to pay for the actual drug, the problem is that we don't have services or personnel to deliver those treatments. So, what NHS England have asked recently is for a longer time of implementation so that we can train healthcare professionals, expand to primary care where these treatments are much better delivered, again, increasing access. They have asked for a rather long time of implementation of about 9 years, and this certainly needs to be reduced. But at least now the healthcare service is thinking about them much more seriously compared to what we have experienced in the last 5 years. People will also ask, is bariatric surgery, which is again as part of our discussion, another treatment for obesity, which is very effective? People are asking if these drugs will obviate the need for surgery, and the answer is no, because there will be a certain proportion of people that don't respond to the medications, or they don't respond enough, or cannot tolerate them. And for those people, we need additional treatments, and bariatric surgery is a really good and safe way of delivering a really effective treatment. People also ask whether the individuals taking the medications need to change their diet and their physical activity, otherwise, the drug will not work. And the answer is that that is a bit of a myth. We know that the drugs will work, whether people change their nutrition or their physical activity. However, it doesn't mean that we should not be asking for that. Because if, in addition to the medication, people change the quality of what they eat, if we address specific psychological underpinnings of their excess weight, as I said earlier on, stress eating, emotional eating, binge eating disorders, etc., then we will enhance the weight loss. But the reason why medications are going to work anyway is because they are a biological treatment for a biological disease. And remember that I said earlier that the symptoms of obesity are high hunger and low fullness. And what these medications do is they decrease hunger, they increase fullness, and reduce the amount people eat. But there are so many other things that we can do in order to enhance their efficacy that are beyond the medication itself.
Thank you for speaking to me today. What take home message would you like to give healthcare professionals?
The takeaway messages summarize some of our key points of discussion. Ask for permission. Don't oversubscribe or overattribute anything and everything to obesity. Be agile when it comes to response to treatment and changing the approach. Do both prevention of obesity, but at the same time, treatment in those that have the disease. and treat both the biological underpinnings and the environmental underpinnings at the same time.
Well, thank you for that. Don't forget that you can claim CPD credits for listening to this podcast, so be sure to go to mimslearning.co.uk to download your certificate and find links to useful resources and further reading. Thanks for listening. I've been Dawn Liz Powell interviewing Professor Alex Miras. This episode was produced by Till Owen. Next week, join us for a studio discussion with the MIMS Learning editorial team.